I'm going to be arguing that the conventional tension-free operation is the procedure of choice for inguinal hernia repair. I want to preface my remarks, though, by saying that I'm talking about the uncomplicated unilateral hernia. I would agree that surgeons should give strong consideration to the laparoscopic repair for bilateral hernias or recurrent hernias, providing the surgeon is properly trained. But the uncomplicated unilateral inguinal hernia is a different story and is much more problematic. This slide reflects the penetrance of laparoscopic inguinal hernia in the United States. And as you can see, it hasn't changed much from the beginning. It still is well less than 15%. Now, just why is that? Well, I think, just as an overview of this talk, that most surgeons believe the benefits just aren't worth the risk. The learning curve is too steep. Why should they endure a stiff learning curve if the benefits aren't that great? And of course, the problem is that at the time that the laparoscopic hernia repair was evolving, the conventional techniques were also improving, and there began to be widespread acceptance of the tension-free concept a la Lichtenstein.
In this talk, I'd like to focus on arguments that support the laparoscopic approach for inguinal hernia repair as opposed to open approaches. First, and this applies to most laparoscopic procedures, we have better visualization compared to open options. With the laparoscope, we are an inch or sometimes even a centimeter away from the anatomy, and we have a magnified view. This allows us to see anatomy that we otherwise would not have seen through open approaches. We also have access to a wider area, and in the inguinal hernia repair operation, this allows us to explore the other side of the groin through the same incisions in a very brief added dissection. We also can see more clearly why other inguinal hernia repair operations have failed, and being able to laparoscopically document and observe the mechanisms of failures, I think, have helped us learn how to prevent the same failures in the future.
So Dr. Fitzgibbons and Dr. Ramshaw, you've each made the case for either open or inguinal hernia repair respectively, so we'd like to continue this debate with a few questions. First, let me ask you about patient selection, because I'm sure, Dr. Fitzgibbons, you don't do open inguinal hernia repair in everyone. So which patients would you select for a laparoscopic approach, and why?
Well, I think I've already addressed the issue of the recurrence in bilaterals, and I think most agree that if a surgeon is experienced with laparoscopy, they should offer that to their patients. So that brings us to the ordinary hernia repair. I will certainly do that if the patient requests it, and there are certain patients that have studied this on the internet and things like that, and they make a decision themselves that they want it done, and I certainly won't refuse to do the operation on those patients. But as far as any other patient, I would usually recommend a conventional for any of the other patients that I see.
And why do you do a laparoscopic approach for a patient who has bilateral hernias? Is there enough of a difference in terms of the pain and return to activity that's what tips the balance in favor of a laparoscopic approach in that setting, or other factors?
No, it's primarily the risk-benefit ratio. I think the risk-benefit ratio gets pushed into favoring laparoscopy because there clearly is quite a bit less morbidity associated with a laparoscopic repair as compared to two groin incisions. I just don't think when you're talking about a unilateral groin incision that the benefit is that great.
Dr. Ramshaw, any comments or thoughts?
Well, I think one other factor is certainly the surgeon, and not that a surgeon should push any operation on a patient, but if a surgeon feels that their laparoscopic approach is going to be a better repair in terms of their skill and experience, then I think that's another factor. The patient ultimately has the final say, but I think there are many surgeons who have gained the necessary skills and can do a better repair laparoscopically than they could through an open incision.
Of course, I'd have to agree with that. If the surgeon was better at it, I certainly would want them to do it. And there's another patient that sometimes I'll recommend laparoscopy for, and that is the patient that has what I call inguinectomy. That means they have pain in the groin, and I'm not at all convinced that it's the hernia causing the pain. And that patient I like to do laparoscopically also to get a look at the other side of the abdominal wall.
We're now going to have some questions and case discussions, and again I'd like to thank Dr. Fitzgibbons and Dr. Ramshaw for their talks today, and and really bringing their extensive experience in the field of inguinal hernia repair to our discussion. I'd first like to ask some questions about open inguinal hernia repair. And Bob, so let's start with you. And in most centers now, mesh repairs have replaced primary tissue repair. So how is the current generation of surgical residents going to be trained in these primary tissue repairs? When they reach a situation where they really need to do something besides put mesh in, how are they going to be able to do that?
Well, I'm sure you realize nobody has the answer to this problem. It's on a lot of people's minds, and almost every program director in the country is worried about the same thing. It's hoped that during the course of residency that there'd be some exposure. We do have situations where conventional repair has to be done, an infected groin, and there is the occasional patient that refuses mesh. I probably have 2 or 3 a year in my practice that absolutely refuse the mesh. And
because they've read there's bad things associated with the mesh, or they're concerned about a reaction to a foreign material, or
it's mainly a reaction to foreign material. I have patients that have reacted to other foreign materials in the past, and so they just don't want it. And I think we just have to maximize those cases and use that material to make sure we do the best we can to explain our patients, because the animal models aren't very good.
One of the points I try to make with our residents is that some of the layers that we anchor mesh to when we're sewing open, they're the same layers that we use to close primarily when we're doing a primary tissue repair. But what they don't get is techniques for doing relaxing incisions and things like that.
Yes, and also there is some, when you do a tissue repair, there is some importance about the depth of the suture and exactly placing it just properly, whereas for the Lichtenstein operation, you can pretty much watch and make sure that everything that's being done is correct. And you know it's correct at the end, but if you're vigilant, but it's a little harder with the tissue repairs.
Let's talk about inguinal hernia repair in women. And we'll start with a 37-year-old athletically active female who has a symptomatic right inguinal hernia. She's got a medium-sized reducible hernia on exam. How do you approach hernia repair in women? Bruce, do you do laparoscopic hernia repairs on them, or do you favor an open approach?
I would certainly offer it. Nothing in the presentation in my mind has given me an absolute contraindication. I would discuss with them the options, but I would offer a laparoscopic approach. And if she's not had previous abdominal surgery, I would approach it with a total extraperitoneal approach and provide the similar repair that I would for a male, except go around the round ligament rather than a vas and vessels.
Because in women there are almost always indirect hernias, and it can be hard to get that sac off of the round ligament without getting into it.
Similar to taking the peritoneum off of the vas, and you're right, and sometimes those fibers will tear and strand. I still try to take it off the round ligament. I think there's been some literature in the OBGYN literature that there's some suspensory role, so I will still approach it similar to the male in terms of leaving that round ligament in place.
I'd like to again thank Dr. Ramshaw and Dr. Fitzgibbons for their talks and for their participation in this panel, and we hope that you will join us for the next issue of Sage's Grand Rounds on Bariatric Surgery. Yes.